Hi everyone, thank you for joining another TOTEM talk. Today or this evening we've got Jonah Powell-Tuck who's teaching for us on TOTEM for the first time. Jonah's a consultant in intensive care, doctor at Guy's St Thomas's, was previously the trust lead for critical care echo until very recently. I believe he's done the DDU exam from Australia, which is renowned for being extremely difficult. But most importantly, he's an experienced educator, one of the co-founders of South London Intensive Care Echo program, which many of you will be familiar with. And today I'm happy that we have him teaching us on tricuspid valve, which is our first talk on the tricuspid valve, and pulmonary hypertension. So thank you, Jonah, and I'll hand it over to you. I'll mute myself. If people want to ask questions during the talk, and if you would like them to, Jonah, then just let people know. Otherwise, save your questions for the end.
Yes, certainly. So I'm new to this Google way of presenting. I'm slightly disappointed to see a bit like Teams. I'm now sort of blinded to everyone else. So all I can see is my slides now. So yeah, do let me know if anything pops up in the meantime, or if there are any problems. Well, thank you for the invite. And firstly, sorry to disappoint you, but you slightly oversold me with the DDU side of things. So I did my Echo Fellowship in, I think, 2015-16 with Guy's and St Thomas's. Me and my colleague Nish decided were the two first people to do that. And then after that, I went off to Melbourne, and there I did a diploma in Echo and point of care ultrasound with the University of Melbourne, but I didn't go near the DDU because that's about 700 cases that they had to do, which is quite a lot. It takes them at least 2 years to go through all of that. Yeah, but then when I came back, I helped John Aaron and Richard Fisher to set up Slice, which I'll plug slightly at the end. Hopefully a few of you have been on our courses. I'll be able to tell you a little bit about that at the end. And then for the past sort of 7 years or so now, I've worked as a consultant at St Thomas's Hospital, predominantly, also a little bit at Guy's. I've been working closely with my colleague Nish Desai in the echo service that we run there. And it's a fairly unique echo service in that we employ our own cardiac physiologists to help us run that, which works really, really well. We've got a group of 4 Echo Fellows who work with us to provide the service. So I've been asked to talk about, well, the title of it is actually right heart valve and pulmonary hypertension, but I understand that you've done some of that over the course of some of the other talks. And so one of the gaps that was highlighted was that no one had yet talked about the tricuspid valve. So we'll predominantly focus on the tricuspid valve. We'll go through some of its anatomy, some of the pathology that you might find associated with the tricuspid valve, and how you go about formally assessing it. You covered the pulmonary valve in great detail, so I'll just do a very brief recap on that. And we'll finish at the end with a little bit of a reminder about pulmonary hypertension, because that's probably the bit that is intensivist. That's maybe the bit that interests us clinically the most. So perhaps not surprising that you haven't done a tricuspid valve talk yet so far. Maybe a slightly underrated valve, but it's definitely within everyone's top 4 heart valves. It's the largest valve out of the 4 of them, with quite a large surface area, 7 to 9 centimeters, depending on the size of the patient. And because of that, and because of the necessity of receiving the venous flow from the body, it operates usually at very low pressure gradients. So we're talking about sort of less than 2 millimeters of mercury. It's comprised of 3 different leaflets, all of which are different sizes. And then it has the usual anatomical components, very similar to the sort of mitral valve, really. You've got the fibrous annulus surrounding the leaflets. You've of course got your 3 leaflets, and then you've got often three papillary muscles and all the chordae attachments underneath it. So this is a bird's eye view of what tricuspid valve might look like. It's ellipsoid, as you can see, and it doesn't have as a flat profile as is made out by the picture here, but it's much more saddle shaped. The superior element of it lies right next to the aortic valve, and you can see the commissure here between the anterior and the septal leaflet is the largest out of the lot, and it sits right next to this non-coronary cusp here. And so there's a real risk when you're doing right heart procedures that you get your equipment entangled in this commissure here, and so there's a risk that you could cause aortic dissection by doing that. Most inferior point is the posterior leaflet here, and that sits close to the coronary sinus. So as we said, it's a fairly large valve, and the circumference in healthy males would be 12 centimeters or so, plus or minus 1 centimeter, with females being 11 centimeters. There's a highly mobile valve, and so that during the cardiac cycle, the annular area itself changes by much to 30%, with, as you'd expect, it being largest at the end of diastole. You can see that all the leaflets are different sizes. The anterior leaflet is the largest and probably the most mobile. Well, the posterior leaflet here is the smallest in terms of circumference, and often has a slightly sort of scalloped nature, sort of giving rise to that sort of saddle shaped nature of the tricuspid valve. Whereas the septal is the shortest valve when you're looking at the radial size of it, and is certainly the least mobile. It's moving again. So it's very difficult when you're doing echo to actually try and work out exactly which leaflet, certainly on TTE, which is what this talk solely focuses upon. And you can see some of the reasons for this from this diagram that I got from the British Society of Echocardiography guidance. And you can see here that on the right-hand side of the screen, we're looking at two different versions of the parasternal long axis RV inflow view. And as I'm sure you're aware, you get your parasternal long axis view, and then you just tilt the tail up so that you're looking down towards the patient's feet. And as you do that, the right atrium and the tricuspid valve could come into view. And you can see the process here of you doing this on this diagram on the left-hand side. So here is your traditional parasternal long axis view, and we've shown it in short axis view here, so you can see the structures that you're cutting through. And your traditional parasternal long axis view, you're cutting through the aortic valve, aren't you? You're cutting through the mitral valve as well, and looking at the basal elements of the left ventricle. But as you then tilt your probe inferiorly, you will then start to see the tricuspid valve. So the first leaflet that you're going to hit is most likely to be the septal leaflet. And if you've got a good view of the coronary sinus within in your view, so you can see it just down there and there, then it's most likely that you're looking at the septal leaflet. And if you see a second leaflet, that's most likely to be the anterior leaflet. Whereas if you keep on pointing your probe down more inferiorly, then you're more likely, as you can see in this view, to come across your anterior and posterior leaflets. So within this view, you're not going to see the coronary sinus, and you're also not going to see the intraventricular septum, which you can see in view A here. So you can see that just slight deflections on how you're angulating the probe will affect what particular leaflet you are going to see. And you get a similar effect when you're looking at the right ventricle and the tricuspid valve, having a look at it through the 4-chamber view here. And here we've got, again, on the left-hand side, we've got our short axis views, and we've got different cuts of how we might look at through the valve and the 4-chamber view, as well as the 5-chamber view. So if we look at image B to start off with, that's your sort of traditional 4-chamber type view. And this is what we're looking at here in cross section. If you imagine that the patient's apex is into the screen, and you can see the aortic valve is coming out of the screen at you. And what we're doing is we're cutting through from the apex along the B line here, so that you can see across the mitral valve and across the tricuspid valve. When you're doing this, you're likely to be seeing the septal leaflet, and you may be seeing the anterior leaflet, or you may be seeing the posterior leaflet.
Now, just to let you know, I'm not sure if it's just on my screen, but your mouse tracker seems to not be following that well on the screen. So
okay.
Just so you know.
Okay, thanks. Whereas if you flatten your probe a little bit so that you're angling the probe, the ultrasound slightly more anteriorly, what you're going to start to see is more of this view here in A, where you're going to be looking at the septal leaflet as well as the anterior leaflet. So if you've got your view and you can see your aortic valve in your view, so your 5-chamber view, then you're going to be seeing the septal and anterior leaflets. Whereas if you're going to tilt the probe more posteriorly, so you kind of get that view where you start to lose the atria and you start to see the coronary sinus come in again, you're going to get more like view C, where you're going to be more likely to see the septal leaflet and the posterior leaflet. And so when you're having a look at the right ventricle and the tricuspid valve, ideally you're going to want to get more of a RV focused apical 4-chamber view. So to obtain this view, you're going to start off with your typical 4-chamber view. And then you are going to most likely need to slide your probe slightly laterally so that you get a bit of a better view of the RV, and so your RV comes into more of the center of the image, whilst ensuring that you don't open up the view to get your 5-chamber view, and the LV outflow tract remains not visible on the screen. You may then just have to slightly rotate the probe until you get the RV diameter at its widest. And then you can start to have a look at the tricuspid valve in more detail. And as a tricuspid valve, the right atrium and the right ventricle all interlink and are very pliable structures. They all need to be examined at the same time. The coaptation length of the tricuspid valve is relatively large. It's somewhere between sort of 4 and 9 millimeters. So there is a fair amount of give for when either the right atrium or the right ventricle does start to dilate. There will still be a reasonable amount of length to allow for some dilatation. Your tensor apparatus down at the bottom here will consist of your anterior and posterior papillary muscles. And in 80% of patients, there will also be a septal papillary muscle too. So the anterior papillary muscle will support the anterior and posterior tricuspid valve leaflets, while the posterior papillary muscle will support the posterior and septal leaflets. And there's a sort of complex network of chordae there that connect the leaflets to the papillary muscles. And in normal patients, there's around about 25 of these, all forming quite a sort of tight mesh within the right ventricle. And as the right ventricle is a very sensitive ventricle, it's very thin, very sensitive to afterload and prone to dilatation relatively easily due to its thinness. You can imagine how any disruption of the RV will then pull these chordae and very easily distort the shape of the tricuspid valve and cause regurgitation by that method. With the sheer amount of chordae, it's quite terrifying, really, when you see it even in dissection or by pictures. When you start to think of all the different things we put into the RV and the pulmonary artery catheters that we thread through, and in interventional cardiology, all the different devices that they thread through the right ventricle. And it's a wonder that these devices don't cause injury or get tangled and trapped more often. But it is becoming increasingly common that you can see injury to this sensitive apparatus that may then result in tricuspid regurgitation. So when we think about tricuspid valve pathology, we can categorize it into both primary and secondary causes of tricuspid valve pathology. When we talk about primary causes of tricuspid valve pathology, we're saying that there is either an injury or a congenital defect within the actual apparatus itself. Whereas by far more, the most common cause of things such as tricuspid regurgitation is that there's been some other structure that is distorted. So that could be the RA, right ventricle, RV outflow tract, or even the pulmonary valve, then leading to other changes within the right ventricle that then causes distortion and disrupts all of that sensitive suspension apparatus that will then pull the tricuspid valve open and cause tricuspid regurgitation by that method. So perhaps one of the most common congenital tricuspid valve disorders that I'm sure you would have all heard about is the Epstein anomaly. And this basically involves the tricuspid valve being displaced superiorly within the heart, moved down the right ventricle, with resultant atrialization of a significant portion of the right ventricle. There's a large anterior leaflet that's often then tethered, and this itself will then lead to significant tricuspid regurgitation. And you can see the effect of that there with the intra-atrial septum bouncing around there. The intra-atrial septum is a great structure to look at whenever you're doing quick, dirty, basic echo, because it'll tell you a huge amount about whether there's raised right-sided pressures, whether the left atrial pressure is high or not, or whether the patient's underfilled. So, a worthwhile thing to interrogate. We can also get primary tricuspid valve disorders that are acquired. Just seeing, there we go. So there can be traumatic injuries, and they can be external. And the right ventricle is most forward-facing within the chest, so the tricuspid valve is prone to injury. We talked about how increasingly common it is now with the increasing amount of percutaneous interventions available, that there may be tricuspid valve injuries, often caused by ruptures to the chordae or entanglement within the chordae. There are infective causes, and obviously this is a case of infective endocarditis with a large vegetation seen on the tricuspid valve, together with numerous other causes, including carcinoid, restrictive disease, and rheumatoid fever, with a sort of stenotic type lesion. Pacing wise, you'll have, I'm sure, in the course of your echoes, noticed that there's regurgitation often associated with pacing wires. For some reason, I'd always assumed that was just the disruption of a wire going through the leaflet itself that was always causing the regurgitation, and there may be some element of that leads to a degree of disruption of the tricuspid valve and coaptation. But equally, there may well be damage to the leaflets themselves, or the subvalvular apparatus, again, that pulling distortion that then leads to tricuspid regurgitation. So that may play an element within it. Also, the timing of contraction of the right ventricle is important, and usually the right ventricle contracts marginally before the left ventricle. And if pacing isn't adequately optimized, the fact that you're pacing through the right ventricle can sometimes distort the relative anatomy in the wrong phase of the cardiac cycle of the right ventricle, and just that action itself, because the apparatus is also sensitive, that itself can trigger a tricuspid regurgitation. But as I said, by far the most common cause of tricuspid valve pathology is secondary tricuspid valve injury. And again, this is where you've got normal structure of the apparatus, but distension of either the right ventricle or the right atrium then causes most commonly tricuspid regurgitation. So the size of the right ventricle and the right atrium all affects the size of the tricuspid aperture. So in secondary tricuspid regurgitation, therefore, the dimensions of the tricuspid valve annulus, the right ventricle and the right atrium, and to some degree the leaflet tethering are all determinants of the severity of tricuspid regurgitation. The tricuspid valve regurgitation itself leads to progressive remodeling of the right ventricle and the right atrium as it tries to compensate for the changes in preloads and afterloads. But this itself only worsens tricuspid valve annulus dilatation. It will worsen the displacement of the papillary muscles and lead to further leaflet tethering. And so you can get in this cycle where once you start to get a TR, it starts to change the morphology, and that tricuspid regurgitation only gets worse. You can imagine in the instance of pulmonary hypertension, even if the right ventricle doesn't dilate to that, but in fact hypertrophies over time, the hypertrophy of the muscle itself will lead to some degree of tethering of the tricuspid valve apparatus and pull the tricuspid valve open, leading to tricuspid regurgitation. And also within pulmonary hypertension, when you've got pulmonary hypertension caused by left-sided pathology, such as mitral valve disease, studies have shown that up to 30% of these patients have significant tricuspid regurgitation secondary to that high capillary pulmonary hypertension. The slides are all being a little bit slow. It's not you. There we go. Okay, I wonder if this video is going to wake up. There we go. We've talked a little bit about as well about how pacing can disrupt the tricuspid valve and cause regurgitation. But equally, it's not just that. Pulmonary hypertension and right ventricular size that contribute, but atrial pathology can also equally contribute. And in fact, some studies have shown that the presence of atrial fibrillation is perhaps one of the strongest predictors of patients getting progressive tricuspid regurgitation. And as that right atria starts to dilatate, again, that saddle shape will be, of the tricuspid valve will start to be lost as the annulus dilates, and AF and atrial dilatation is actually probably one of the most common causes of tricuspid regurgitation. And it's not a minor disease. It's something often that a lot of people overlook, but it does have impacts upon mortality and morbidity, particularly on the severer end of the spectrum. So in studies, when they looked at patients who had undergone left-sided heart valve surgery, it found that patients who had developed tricuspid regurgitation after their operation, so after all of their valvular problems on their left side have got fixed, did very, very poorly, and that was a poor prognostic marker. And they could predict which patients were more likely to develop significant TR afterwards, as these were the patients who developed post-operative AF. There we go. So how do we go about assessing the tricuspid valve? Well, there are obviously lots of views in which you can see the tricuspid valve, and the first of which you'll come across if you're going through your structured TTE examination will be your parasternal long axis inflow view, but you'll know it's also visible on parasternal short axis. You can see it on your four-chamber, and more specifically, you could try and do a focus RV view within your apical four-chamber. You see it on your subcostal view, and interrogating the patient's IVC will be useful in quantifying the degree of disease. Thankfully, most of my slides are pictures rather than videos, so hopefully it should speed up a little bit. Here we go. So most of you will be familiar with putting a bit of a colour flow Doppler onto your tricuspid valve and determining the degree of tricuspid regurgitation using that method. And I suspect most of you are going to be familiar with that, and fairly happy to call the severity of the tricuspid regurgitation by simply doing that. But you have got to remember that the determinants of the size and the color of the jet are determined not only by your color gain settings, but also by the momentum of the regurgitant jet and the direction in which it runs. So if you've got a tricuspid jet that is faster, a bit like a Venturi mask, it will start to entrain blood that is already within that receiving right atrium. So you might find that a very thin but a very high velocity jet that's coming through a sort of narrow aperture, so actually not that severe a TR at all. In fact, the mildest of TR may actually look much more dramatic on the screen than it actually is, because the thin jet's coming through, it's entraining the blood from around the right atrium, and then it's almost creating a vortex, and can look surprisingly dramatic, whereas in actual fact the real TR is relatively small. Obviously, the higher the pressures of the right ventricle will increase the driving pressure and increase the jet velocity. So the higher the pressures are, the higher the jet velocity will be, and so the larger this entrainment factor will be. But equally, if you have someone with very severe TR, because of the very large orifice of the valve, you may get relatively low velocities of regurgitation coming through the tricuspid valve that might be difficult to interpret. They will have very little, if any, entrainment of the flow of the right atrium, and so might therefore lead to a misleadingly small colour jet, because there's no high velocities, and that the regurgitant jet is spread out over a larger area and looks less dramatic. So as a result of this, the regurgitant volume of the TR may actually be larger. If we look at the mitral valve, where the pressures are higher, we might actually see that when we're comparing with the tricuspid valve, which looks far less dramatic, might actually have a larger volume of regurgitation than the higher velocity mitral valve. And we talked a little bit about the geometry of the tricuspid valve, and it's possible to have a regurgitant jet that has multiple different jets going off at different angles. And so these multiple jets makes it very difficult to determine exactly how much regurgitation there is. And there may be actually cumulatively quite a significant hemodynamically significant volume of blood flowing backwards. It's very difficult to actually pick up and interpret on the echo. Whenever you're assessing any of the right heart valves, you also need to do this in conjunction with assessing the right heart sizes. Obviously, this is tricky because the right heart is a funny shape. In actual fact, with outpatients, often it's easier to do a cardiac MRI than it is to do an echo, and you get better estimates of the volumes of the right ventricle. But there's BSc guidance that you can look at, and that have been discussed before in other talks, and exactly how to measure the right side of the heart. But that's all going to be important information to gather to try and help you determine what's causing the patient's regurgitation. You also need to assess the IVC to try and determine how far this regurgitant jet is coming back. We'll talk a little bit about some of the spectral Doppler studies that you can do to assess with that. So overall, in your visual assessment of looking at tricuspid regurgitation, you're looking at the structure. As with any echo, you want to pan through, so you can try and determine, even if you won't be able to necessarily name each of the 3 leaflets, have a rough idea about what's happening with each of the leaflets, and trying to work out where the regurgitant jet is coming from. Have a look at the movement closely, particularly within the 4-chamber view, and try to determine if there's any degree of tethering or tenting. Is there a prolapse or a flail? Or is this a coaptation, a defect caused by either atrial or ventricular dilatation, or both? In your 4-chamber view, you can measure the size of the annulus, and in the extreme, when you get an annulus size that is greater than 4 centimeters in diameter, and you can say that that's enlarged, and that's associated with severe tricuspid regurgitation. Another measurement that you can consider doing is measuring the tenting area, which is shown on the image on the bottom left of the two images. And what you do for this is you cycle through to end systole, and you're first of all the distance between the 2 annuluses of the tricuspid valve, and then you're measuring through to the coaptation point of the leaflet and forming a triangle. You can work out the area, and it's said that if the area is greater than 1 centimeter squared, then there's likely to be more than mild tricuspid regurgitation. In fact, they've done studies and had a look at this value after tricuspid valve surgery, and if you have a value greater than 1.6, that suggests that there's likely to be a poor outcome from the surgery. An alternative is you can just measure the height from this horizontal line, measuring the annulus diameter. You can just measure the height from that line to the coapted leaflet and measure the height. And post-cardiac surgery, a value of greater than 0.76 suggestive of significant residual tricuspid regurgitation after tricuspid valve surgery or repair. But as you can imagine, this is quite difficult to get the exact measurements in these patients. And as you know, getting these views within critically ill patients is extremely challenging. So let's go on to color Doppler. There are a variety of different tools that you can use, as well as your visual assessment, that probably forms the majority of assessing how severe the tricuspid regurgitation is. All of these measurements at the top here, just like when we're having a look at the color Doppler, are all dependent on the number of jets, the size of the jets, and very much dependent on the different pressures between the 2 ventricles and the preload and afterload. And this is just a reminder, when you're having a look at color Doppler, that you really want to be setting your Nyquist limit to between 50 and 60 when having a look at the tricuspid valve. You can have a look at how far the jet goes from the valve to the back of the right atrium, and on those where you get a sort of deep hollow systolic jet, and they're more likely to be severe. But just be aware that we talked about all the different confounding factors that can affect that. You can determine whether you think that the flow is small, intermediate, and large. And again, that's just sort of eyeballing it. And you can measure the jet size. You can measure it in terms of centimeters squared, where greater than 10 centimeters squared might be suggested of severe. Or you can do it as a ratio of the jet area compared with the area of the right atrium. But of course, remember, this isn't going to be particularly helpful. Particularly if you've got a jet that's very eccentric and the size of the jet is sort of constricted by the structures that it hits. And this is a separate reminder as well, that because these measurements are all so much dependent on pressure, we can see here that there's similar shaped envelopes of regurgitation in the mitral valve and the tricuspid valve. In fact, the tricuspid valve regurgitation jet is slightly smaller, but we've got to remember that the velocities are much higher through the mitral valve compared with the velocities and pressures that can be lower in the tricuspid valve. And so actually this probably represents a more severe regurgitation. So sort of getting your eye in for what's severe in a mitral regurgitation might not be the same as getting your eye in for a tricuspid regurgitation. I don't think a lot of people appreciated this. And this just shows what is obviously looks like a severe tricuspid regurgitation. It's got quite a wide vena contractor there. You can see the force of it sort of wrapping around the right atrium there. But clearly, if this jet is just directed straight backwards, it's going to be much wider than if it wasn't constricted by the intra-atrial septum. Vena contractor width is the next thing that you can try and measure. It can be quite challenging to get the views on this. You can maybe try and have a look on your inflow view to see if you can get this. And so that's just going to basically be the narrowest part of the jet on color Doppler as it passes through the tricuspid valve. But because of the shape of the tricuspid valve, and it's similar with the pulmonary valve, it's actually really quite difficult to determine exactly where your vena contractor should be measured, particularly on your 2D views. It is slightly more accurate if you're going to go into 3D echo, but you really should treat this with caution, and only really trust it if you're sort of getting sort of way into the sort of severe end of the spectrum, so greater than 7 millimeters, because it is just so inaccurate. Similarly, you can start to consider whether you're going to use Anaesthesia, or whether you're going to start to try and calculate effective regurgitant orifice areas. I personally don't do this on tricuspid valves because of the different shape compared with a mitral valve. Your Pisa dome is often much flatter, and it's a challenging thing to measure, and is also prone to much operator interdependence and error. And within a critical care environment, I'm not sure how useful it is. Perhaps for your sort of quick sort of basic screening echoes, this is perhaps more useful. Sticking continuous wave through your tricuspid valve, and then just having a look at the shape of the regurgitant jet, and having a look at the density of the regurgitant jet. So you can compare your forward flow compared with your backward flow. And here you can see that we've got really quite a dense tricuspid regurgitant flow pattern here, which might be more at the severe end of the pattern as well. You can have a look at the shape, and whereas your sort of less severe tricuspid regurgitation would be a nice sort of dome-shaped picture like this. Once you start to get a sort of early peaking jet with a sort of knife-like appearance like this, it's more likely to be severe. But of course, you've got to make sure that you've got adequate signal. Remember that on the right side of the heart, the flows through the right side of the heart are much more dependent than on the left-hand side of the heart on your respiratory cycle. So your respiratory cycle will affect these values. So it's important that you wait for, at least depending on the patient's heart rate and respiratory rate, at least for 5 cycles to average out the three of them. We can also have a look at your E velocities, and then we can go on to have a look at the IBC. And it's said that if you get a peak E velocity of greater than 1 meter per second, then that might be suggestive of severe tricuspid regurgitation, provided that there's no tricuspid stenosis, which would obviously start to interfere with the E velocity. And so here we go. This is how we might measure the patient's E velocity. So we've got a pulse wave just where the cuffs collapse, and then we're having a look at the inflow. We're having a look at the E wave, and we're measuring the height there. And once you get above 1 meter per second, so about this height, then that might be suggested, provided there's no other tricuspid valve pathology of severe regurgitation. But again, perform this over 5 cardiac cycles so that you can average out the effect of the patient breathing. And then we can go and have a look at the hepatic vein flow. And once you start to get, certainly once you start to get systolic reversal in your hepatic veins, then that's suggestive that there might be severe tricuspid regurgitation. And certainly the systolic reversal is much more sensitive and specific than just the systolic blunting itself. And you'll start to see the SD ratios start to invert. So here we go, having a look through the hepatic vein, and you can see that there's some systolic reversal in this case that might be indicative of severe regurgitation. So there we go. So summary of the tricuspid valve interpretation, and looking explicitly at regurgitation. Well, it's a difficult thing to assess because it relies on so many different factors. It relies on the patient's respiratory cycle, relies on the relative pressures between each of the chambers, and it's very, very sensitive to that. So the basic simple things that you can do if you want to do a brief assessment, let's face it, in intensive care, I think most of us haven't really got time to sort of go down and start to measure, try and calculate out PISAs and go into it in such depth. But the basic things we can do include having a look at it in 2D and all the different views that we can muster, measuring the diameter of the annulus, and if that is big, then that might be suggestive that the regurgitation is severe. Having a look at the continuous wave Dopplers, and having a look to see whether that knife-like triangular type flow pattern with the early peaking jet. Having a look at the relative size of the areas of the right atrium compared with the jet area. If you can, vena contractor width, but again, that's quite an unreliable test to do. And then the start of VEXAS, having a look at some hepatic vein flow. Remember that you need to concurrently evaluate the right ventricle and the grid pulmonary hypertension to be able to get an in-depth picture as to what the patient hemodynamics are. And remember that I suspect most of us on this call aren't cardiologists. Lots of us intensivists, ED physicians, emergency physicians, and acute medics. And so what we're interested in is, are these lesions hemodynamically significant? And I think that's slightly different to sort of grading the severity of the the valve lesion, although of course there is some overlap. Remember that there's a huge amount of caveats, which is why you want to use multiple of these assessment tools. And we haven't even begun to talk about this in the context about ventilators and hemodynamics. And we know that that can all change rapidly based upon all of the nasty things that as intensivists we do to patients' right ventricles. The right ventricle is a very delicate structure, and you may see worsening tricuspid regurgitation as an early sign that the right ventricle is stressed. And so when you notice it, it is a marker of a poor outcome. So you might want to think a little bit more about whether there's more you can do to be perhaps a bit kinder to that right ventricle. And also start to think about the effect that this is going to have, not only on your venous pressure and venous congestion, which we increasingly know is a problem for all of our organs and a common cause of organ failure within in intensive care, but it's also going to start to have an effect on your cardiac output, because of course cardiac output can only ever equal what goes forwards through the right ventricular system. And so venous return is important. If you're losing a proportion of that, then that's going to have a knock-on effect on your cardiac output, your, if you like, slightly more sexier left-hand side. And then very briefly, how does this then impact upon decisions about surgery? So it still remains controversial as to the timing of surgery and when we should do surgery, but this is from the European Society of Cardiology, this little flow sheet. And increasingly it's being recommended that for patients who are already going through valvular surgery on the left-hand side of their heart, if they've got significant tricuspid regurgitation, you really should consider whether you should repair the tricuspid valve at the same time. And it's for the reasons that we've already talked about, where we know that if there's patients that do have tricuspid regurgitation, that tricuspid regurgitation is likely to continue to get worse even after corrective surgery on the left-hand side. We know that that's a poor prognostic sign. Even if the degree of regurgitation is mild or moderate, if there are signs of right heart failure with that or annulus dilatation, then it's suggested that the patient should still have surgery. If they're not otherwise having surgery, and obviously having a surgery on the tricuspid valve alone is a bit more of a major thing that carries risk. They've got a primary defect in the actual apparatus itself and they're markedly symptomatic, then they should go through to have a tricuspid valve repair or replacement if absolutely necessary. But if you've got secondary tricuspid regurgitation, you've got to ask yourself the question, is there a severe abnormality in either the LV or the right ventricle, or indeed pulmonary hypertension? And if there is presence of that, then the patient should just be treated conservatively, because changing the valve isn't going to make any difference to this. And so I've explained it in slightly a reverse way to the picture, because they say an absence of and then no. But essentially think about it, if the RV is abnormal, if the LV is abnormal and there's pulmonary hypertension, then you're not going to be offering these patients valve surgery. Whereas if all of that is normal and they're markedly symptomatic, then you might offer them a repair. Stenosis I won't dwell on. I, to be honest, don't have a huge amount of experience in this. I think it's more specialist and outpatient territory. But very briefly, you'll go through visualizing how the leaflets looked, and noting how there is reduced opening of the leaflets. Although again, this can be difficult to entirely image on your 2D views. The presence of right atrial dilatation and increased IVC signs, obviously non-specific signs that there may be a stenosis. But the key thing that you're looking for is an increased mean gradient. Once you get greater than 5 millimeters of mercury, then that suggests that there's a significant tricuspid stenosis. Although, of course, it's very sensitive to preload and afterload, so that a significant TR will falsely elevate the mean gradient. And you can go on to calculate pressure half times. So this is how you might want to do it with pulse wave Doppler, and so you basically you measure the slope, and then you can calculate the pressure half time by, you take the B max and then you divide it by 1.4, and that's what they're doing along the slope, which gives you this red line here, and will then give you the pressure half time. You may be familiar with a mitral valve and calculating whether there's severe stenosis. You do 220 divided by pulmonary hypertension. When a tricuspid valve, they found that 190 is better a value to use to calculate the area. And if you calculate the area and it equals less than a centimetre squared, then that is likely to be tricuspid stenosis. But again, difficult measurements to do, particularly in the intensive care environment, and prone to error. Alternatively, you can calculate the mean gradient by having a look at the area under the curve, and if you get greater than 5 millimeters of mercury, then that's suggestive of severe stenosis. We'll skip over the pulmonary valve. You've covered that before, and then we'll just have a very brief reminder of so there we go. There's some of the key values that you're looking for in diagnosing of stenosis and severe regurgitation. But very briefly, we'll go through and just remind ourselves about pulmonary hypertension. So pulmonary hypertension is when you've got pulmonary pressures of greater than 25 millimeters of mercury, and untreated leads to high mortality and morbidity. You can grade the different subtypes of pulmonary hypertension, and that's important because you need to understand what the cause is, so the causes have all got different treatments. So a WHO graded it into 5 different groups. The first one's sort of more like it's an idiopathic, so primary pulmonary artery hypertension, which is group 1. Group 2 is pulmonary hypertension secondary to some form of left heart disease, often diastolic failure or valvular disease. Group 3 is pulmonary hypertension secondary to lung disease, so you think your interstitial lung diseases, your severe COPDs maybe. And then separately to that, you've got your group 4, which is your chronic pulmonary hypertension secondary to chronic pulmonary emboli. And then finally, you've got 5, which is either that it's unclear or that there's multiple different mechanisms that are all contributing towards it. As with anything on the right hand side, when you're assessing for pulmonary hypertension, go through and take your right ventricular measurements first of all, and look for visual signs of the pulmonary hypertension. And sometimes you don't need to go further than that. You can look at the intra-atrial septum, you can look at the intraventricular septum. Various measurements, as I'm sure you know from previous talks, that you can do with the RV, but just remember the RV shape is quite a challenging one. It's you don't do it on your sort of traditional 4-chamber view. You need a slightly sort of adapted 4-chamber view to do some of your measurements, and just be aware that the calculations of volumes that you might get might not be as accurate as 3D or indeed cardiac MRI. You can have a look at the right ventricular wall, and that might give the thickness of that, might give you some idea as to the chronicity for pulmonary hypertension. And you should interrogate the left-sided valves, left ventricle, to look for any left-sided cause of the pulmonary hypertension. Now, you can measure the pulmonary artery pressure by interrogating a tricuspid regurgitation. Most patients have a degree of tricuspid regurgitation, and you just need to cycle through your views, your parasternal long axis RV inflow view, your short axis view, and your apical 4-chamber view, to get the view in which your jet is going to align the best with your Doppler signals. And don't be afraid to do a really off-axis view, for example, on the 4-chamber, to try and get that alignment as accurate as possible. And then hopefully you'll all be aware of this formula to convert pressure, convert velocity, through to pressure. So you're having a look at the regurgitant jet, you're having a look at the peak velocity of regurgitant jet, and then you're using this formula here to calculate what the pressure difference is between the right ventricle and the right atrium. And then if you add the right atrial pressure to that, then you should get an estimate for the pulmonary artery systolic pressure. So rough rule of thumb, if your peak velocities are greater than 3, then the patient's very likely to have pulmonary hypertension. So that's how we've traditionally done it. But recent studies have suggested that although using this method, using the simplified Bernoulli equation to calculate the regurgitant velocity, adding it to right atrial pressure to then calculate whether the patient has pulmonary hypertension or not. Well, those studies have shown if you look at whole cohorts of patients, it's relatively accurate when looking at a cohort in predicting whether any one individual patient has pulmonary hypertension. It's actually pretty poor. And some of the reasons for that is you might got good alignment with the Doppler traces, because of the calculation where you're squaring your velocity and then times it by 4. Even small errors of where you measure that the velocity can magnify out quite significantly. You should also remember as well that in outpatient echo, they're estimating what the patient's RAP is, and actually we know that looking at the IVC isn't actually a particularly great way of calculating exactly what the RAP is. And so the BSE now suggests using this algorithm to determine, probably like most things in medicine, and probably quite sensibly, rather than saying whether the patient definitely has pulmonary hypertension or not, they determine whether the patient is high, medium, or low risk of having pulmonary hypertension. So you start off having a look at your tricuspid velocity as before. If it's greater than 3.4 meters per second, then that's very high. They're almost definitely likely to have pulmonary hypertension. If it's low or not measurable, then you need to have a look at 2 other of these 3 echo categories. You need to see whether the right ventricle is enlarged with some degree of septal flattening. You need to have a look at the pulmonary artery and have a look at the pulmonary artery, the pulmonary valve regurgitant jet. And if there's a velocity of greater than 2.2 meters per second, or the acceleration time is the systolic acceleration time is less than 105 milliseconds, or there's mid-systolic notching, then that counts. And then finally, you can have a look at the IVC and see whether the IVC is dilated or whether the right atrium is dilated. So if you have any one of 2 of these categories and you've got low pressures, then you might move into an intermediate risk range. And then if you've got intermediate values with your tricuspid regurgitation, you're looking to see whether you have 2 or more of these different echo criteria that will move you either into the intermediate or the high risk. But actually, in terms of the outpatient department, the only real way of telling whether the patient has pulmonary hypertension is to refer them on to a cath. And if you feel it's going to make a difference to them, then they'll go to cath lab and have those measures measured. We can have a look at the regurgitation through the pulmonary valve and find out more about the pulmonary pressures. So you can have a look at the early diastolic pressure measured here, and you can calculate the mean pressure using this formula here, provided you've got an accurate right atrial pressure. Having a look at the early velocity, if the measurement is greater than 2.2, then that suggests that your patient is likely to have pulmonary hypertension. You can also calculate the diastolic pulmonary pressures by having a look at the end diastolic value, so just before systole, see what the pressure is, and that will give you an idea as to what your diastolic pressure is using that formula. For the people who just like glancing at Doppler signals, this is probably slightly more useful for you and maybe less prone for error. So this time we're looking at the systolic flow through the pulmonary valve, and you can see that there's a nice sort of dome shape, a parabola, and a shape curve if you've got normally pulmonary hypertension. As you start to normal pulmonary pressure, sorry, and as you start to move up to moderate pulmonary hypertension, what you'll see is your acceleration time, so the time from the beginning of systole to the peak of the trace, will start to reduce. So you start to get this sort of almost knife-like shape in moderate. And when that goes through to severe pulmonary hypertension, that acceleration time keeps on reducing. When you get acceleration time less than 105, I've written seconds, but it's milliseconds, then that's definitely milliseconds, then that is likely to be severe, and you start to get this notching here. So you move from a sort of so normal everyday knife to sort of a horrible sort of zombie type knife blade there with this horrible notch in it. If you see that, then it's likely that the patient has severe pulmonary hypertension. So there you go. There's some of the formulas that you can use. You're looking for a low acceleration time in the systolic waveform with mid-systolic notching. Might suggest pulmonary hypertension. Or you're looking for those very high tricuspid regurgitation velocities or tricuspid regurgitation velocities that are sort of medium with two separate heart signs of raised right atrial pressure. But remember that all of this is in the outpatient setting. It hasn't been validated in critical care patients, particularly not those ventilated critical care patients. And we know that the degree of pulmonary hypertension fluctuates, depend on what you're actually doing to the patient. And so maybe I'd argue that actually we might be slightly better at this initial measurement there, particularly in the patients that have a central line in one of their jugular veins, because then we're going to be able to accurately measure the right atrial pressure. And so that's going to be one less inaccuracy when we try and calculate the pressures from the tricuspid regurgitation. But just remember, none of this is validated in ICU, although that's not to say that this doesn't form a very, very important part of our echo assessment, because it gives us so much information about the right-sided hemodynamics. We get to understand about right-sided preload and afterload, and then can base our hemodynamic as well as our ventilatory decisions based upon the values that we get. And even if our values are slightly off, there's potentially less harm to be done by making a change than repeating exactly the same test and just seeing whether your values are getting better or worse. So that's all I've got to talk about really. So it's a bit of a rattle through. So we've mainly discussed tricuspid regurgitant analysis, and we also covered a little bit about pulmonary hypertension. Just got to remember to, when we're doing any of this, do it in conjunction with assessment of the right heart. We also need to have a look at the left heart to see how the left heart is impacting upon the right hand side. Pulmonary pressure is a fairly easy measurement to make in the ICU, and they're really very useful clinically. So increasingly, I'm finding when I'm doing my echo, I'm sort of doing more and more sort of Fusic style echoes, mainly because I haven't got the time to do a full echo. We've got an excellent echo service who can do that for us. But I find that most of my clinical questions are answered by Fusic with a bit of color, but there'll just be two other Doppler studies that I mainly do of it. I'll calculate the cardiac output, and then I'll have a look at the right-sided pressures as well, because they're the things that make the most difference to me clinically. And so overall, I think echo has been a really, really valuable skill for me to learn. Use it on a daily basis, but mainly as a screen rather than a full all singing, all dancing echo. We just got to remember, though, when we talk about echo, there's a lot of echo chat on Twitter and stuff. We just need to remember it's just another small tool that we use when having a look at the rest of the patient to help guide us to the decisions. It's never going to tell us 100% this is definitely what's happening, that's definitely what's not happening, but it might make us more or less certain about a specific diagnosis. Remember that echo within ICU hasn't been researched particularly thoroughly. That's not to say that there aren't really excellent people who are doing some really good work in it, but the numbers aren't plentiful. And if we compare the evidence that we accept in echo research and compare that with, say, how we treat pneumonia or ventilator strategies, we wouldn't really change our practice with ventilatory strategies based on a study of sort of 50 to 80 patients. But as echo research is so hard, that's what we're making a lot of our sort of judgments on, and the vast majority of echo has been done in that outpatient setting rather than within intensive care. And then my final thing, the thing I see probably most common with the people that I teach echo, is as you start to get good at echo, you start to convince yourself that the images that you see need treating. You'll see a really poor LV, you'll see a really poor RV, and you want to treat it. You'll add on the lever cement, and you'll add on the melanine. But don't forget that you're treating the patient rather than any of these fancy numbers that you can create. If a patient in front of you looks absolutely well, maybe you don't need to touch them, because remember, all the interventions that we do as critical care doctors are all fundamentally harmful. The sedation that we give them. In the Schumacher period, we know that sort of optimizing everyone to the max was not the right way to go. And so more and more frequently, I've seen people overly treating the echo, but just forgetting that actually patient lactate's fine. They're walking around, they're peeing. Maybe we'll just leave them alone and leave them to the cardiologist and not try and boost their heart a little bit more. So here's some of the resources that I heavily use to create this talk. So have a read of them, because they're all mainly from the BSc or great documents. If you prefer things a little bit simpler, 123 Sonology is really good. And then Slice have our own website as well, which is criticalcareecho.com. So go and have a look at that and have a look at some of our courses. Thank you. Sorry, I think I might have overrun slightly.